mixed session. So I'll be talking about something common facts and diagnostic management. I do not have any financial interest. So let's first start with some. Allergic eye diseases are common and underreported. True or false? Any response?
True.
It is true. In fact, in US, 36% of US population suffers from allergic eye diseases. From India, the hospital-based prevalence is 10.3% and increasing last few years by three folds. Again, majority of the eye itching arises from ocular allergy. True or false? It is false. So there are several reasons of itching. So dry eye is another important cause for itching. Again, another question. Which of the following is not a common cause of eye allergy? Like moles, grass pollen, cat dander, perfume and dust. The answer is perfume. It doesn't cause allergy by allergic mechanism, it causes ocular irritation. So the mechanism is different. Which is not a major symptom of eye allergy? B. Gritty and dry sensation. It is not a major cause symptom of allergy. Individuals who wear contact lens may use ocular antihistaminics to treat their eyes for allergy, yes or no? The answer is yes, but has to be carefully. So some time gap has to be given. So you know the traditional classification of allergic, you all know in this room, seasonal, perennial, some are IG mediated allergen triggered, some are mixed IG and non-IG mediated, and giant papillary conjunctivitis is non-immune mediated triggered by microtoma. And you know that 64% of the patients symptom of allergic, somebody says there's allergic rhinoconjunctivitis, and you know all the details of differences between all different types. But the other type we used to see that contact dermatitis or contact blepharoconjunctivitis, like typical example is atrophic allergy. And another group we see that is frecklenolar keratoconjunctivitis. The mediation is different, but the commonest organism is Staph aureus, and in our country tuberculosis is also very important factor. This is also allergic eye diseases. This is true or false? Vernal conjunctivitis is a misnomer. True or false? It is true. Because now we see it is perennial, no seasonal one. So I will give you some recent reports on allergic eye disease. Like this is, we are just discussing just before, air pollution and allergic eye diseases. And you know that there are significant correlation of PM 2.5 level. Everybody knows what is 2.5 level. And you see a lot of papers has come in last 3-4 years. You see that from Japan, from China, you know the horrible cities with allergies, and they have already the meta-analysis is also going on that how the air pollution and allergics are also important. This is Gurgaon. You see that in Gurgaon, the PM 2.5 level is between 97 to 400. So you must be, if you walk in the road, at the end of the day, you will have some ocular allergy. So what about industrial parks and rural farming? The people have also farming environments are better rather than industrial. Like this is, Gurgaon is an industrial belt. So you must be that those people, the patient demography is so important now with the allergic disorder. This is also interesting paper I read recently. The prenatal maternal paracetamol exposure and vitamin D deficiency with seasonal allergic, there is direct correlation is there. We have to find out, we have to take in the history list that paracetamol intake by the mother during antenatal period. Then you know that this is also a newer things, that vitamin D3 level and ocular allergy. So there are a lot of papers in there. Actually, in fact, after reading these papers, we have started doing it, and we have seen some of the children, they are also serum vitamin D3 level deficiency. So diagnosis of allergy mostly clinical, so allergy history is crucial, and you know the how to examine them. But there are certain things that you can help skin prick press for specific IgE test, sometimes TRIg level, and vitamin D3 level in the serum. So, so is it make sense to have allergy testing to determine triggering factor for allergy? Yes or no? It is true. So if you take 100 patients, you'll find they will detect, and if your treatment directed towards the cause and avoidance of those allergens, you will find that yes, they are benefiting. Then all these are important. You know that all of the above are the treatment. So there are a lot of papers on serum Ig, TRIg, and allergen specific ID. People are working on it, and their treatments are coming on regularly. So which are the followings are appropriate for allergic eye disease therapy? You know the answer. So all of the above is the answer. So treatment guideline, first guideline will be like allergen identification and avoidance. Avoidance of eye rubbing, that is, has to be told to the patient, we know why. Then cold lubricant is better, cool compress, topical dual acting antihistaminics, then oral antihistaminics, use of full of nasal corticosteroid spray, avoid contact lens or in specific time. Then second line treatment is we have some preservative free and also the corticosteroid therapy. And then subcutaneous immunotherapy or sublingual immunotherapy is also there. Short course of oral corticosteroid in some patients, subtarsal injection of triamcinolone in small dose in some of the difficult cases. Then you have third line of treatment like topical cyclosporine, topical tacrolimus, then we have oral cyclosporine, then this is omalizumab. So there are guidelines, there are many papers on use of cyclosporine A and tacrolimus, and many of our colleagues are using we know that these are wonderfully works in many, but you have to be restrict the duration of the use. Allergic chemotherapy, so is immunotherapy is the last part. You see that either it can be subcutaneous or sublingual or omalizumab. There are specific guideline in it. So if you go through this, all this paper from allergy and all these journals, they have a specific guidelines there. And lastly, that omalizumab in refractory VKC, there are few reports, but the thing is that the expensive patient might not be afforded. So take home message is allergic conjunctivitis is an epidemic in 21st century. So you have to think about the air pollution, particulate matter, and all is important. More urbanization, it is increasing. Serum D3 level is important. And diagnostic now will be changing after some time. Identification of allergens are important and desensitization required in specific cases. Systemic immunomodulation may be helpful in severe cases. And you have to have multidisciplinary co-management with your allergy specialist who are treating this kind of more than us. Thank you very much for your patience hearing.
As Dr. Revati is setting up her slides, sir, one quick question to you. What is your standard protocol in managing or approaching ocular allergy?
So we use a lot of oral antihistaminic rather than topical. Oral histamine in the form of Montelukast is quite common and well tolerable. We prefer less steroid rather than we prefer tacrolimus. Tacrolimus not more than 3 months. Initially BD for 6 weeks, then 1 OD for children for another, because it is black box drug. So you may not, there are 1 or 2 incidental report about OSSN after tacrolimus. So you have to be, so the patient will be fine about 1 season. If you give for this 6 weeks, they will be covered that year, you will be covered. You need not to continue. Maybe you can eat, and the application, is very important. It is very irritant. So you ask the patient, half of a rice grain we used to tell them, less than 5 millimeter in size, don't from here to here, then the child will not apply for the next day. Thank you.
Thank you